in, he's complaining of some cervical issues. So chief complaint, onset, mechanism. And with the C-spine, I really want to find out, is it sharp, localized pain, or does it radiate down into your shoulders? Does it hurt more when you flex, or does it hurt more when you extend? And when he does that, is it localized, or does it radiate down in? Hard to appreciate swelling, right, in the upper extremity, or in the cervical. Can you scoot over towards the stairs too? So, wouldn't that be funny if it went whoop? That wouldn't be funny at all. I do start here, just at the base of my occiput bone, and palpate down on the soft tissue. We've got the longissimus capitis, the spinalis capitis, my upper trap, as it goes down into my levator scapula. Those are notorious for being overactive. Onto my C-spine here, when I have them flex, I can look and see bony prominence. The superior of those two is going to be C7. The inferior of those two is going to be T1. To kind of make sure I'm on that spot, I'll have them go ahead and come on back, and I can make sure that they're in line. My C7 is with the acromion. T1 is off of the superior angle of my scapula. And so if I'm on C6, then I'll move up to C5, C4, just to make sure that there's no tenderness on those spinous process. Okay? Now, I've palpated the musculature, the occiput musculature, and the bony structure. We got the spring test along with that. Then I'm just going to move around to the front, see if there's sore anywhere here in the front along the scalenes. To make sure I'm on sternocleidomastoid, I have him push into my, actually push the other way. I can get that sternocleidomastoid to pop out on me. So I'm on the sternocleidomastoid and make sure he's not sore. I can do that bilaterally. And then if we look here, right where it caves in here, that's my neurovascular bundle. So here's my clavicle. We've got the sternoclavicular joint. We've got the convex to the concave. I'm going to dive right in there. My scalenes are sitting here, sternocleido. I'm going to dive right in there and see if there's a little tender right there. And you can usually find a tender spot there. So I've got my neurovascular bundle right there at Erb's point. Okay? So once I get through with my palpations, then I'm going to move into his active range of motion. Go ahead and tuck his chin to his chest and then all the way back. And then I'm going to have him laterally bend from side to side. Now, I had him do a little bit of this and then rotation. Had him do a little bit of this because I asked him which one hurt more in my history. When you flex or you extend, which one gives you the most problem. And now I just want to make sure that everything's working good, so I can push against my hand here. In the back, we've got our upper tract, levator scapula, sternocleidomastoid in flexion, and then whenever he turns, we've got sternocleidomastoid as well, and then pushing into my hand, scalenes, making sure that everything works. I just want to make sure that he's neurologically intact. Not really a dynamic stabilizer here in the cervical. When we're doing the knee, we do it mostly for patellofemoral. When we do it in the ankle, we're really looking at the stabilizers around the ankle themselves, those dynamic stabilizers. We'll do the same thing, cuff and the shoulder. But here we just want to make sure they're neurologically intact with that. Then I get into my passive, right? And so I will, ask him if it hurts, push him chin to chest, go ahead and lean all the way back. And then when I get into my lateral bend, I'll just combine that with my lateral bend with my brachial plexus traction test. And I can do that on both sides. So I get a little traction, I'll get a little compression, right? Depends on where they're getting their pain. Does that radiate down into his arms? And then we can rotate and just have him turn and see if it causes any problems. Sometimes you're just dealing with a wry neck, right? And so they've got a lot of levator scapula. We got to do some release. Then we'll come in here and have him as neutral as we can. And I'll do a cervical compression, and I'm going to ask him, does that recreate pain centrally located or down into his arms? Does that radiate it down? And then with their head in that position, I'm just going to have him tilt over, so I'm going to narrow that space more, and then laterally bend and extend, and push down from my spurlings. Suspecting anything going on with the disc, we've got our modified Valsalva. So you're going to blow into your hand without air exchange. Push hard, looks like that. Does that recreate any pain? Or he may have told me in his history, so place hand up on top of your head like this, and he's going to have him hold it up here for about 30 seconds to see, does that ever make your symptoms go away? If he didn't give it up in the history, you might ask him that, so when he's laying in bed, do you ever place your arm up here, shoulder abduction test to see if that gets better while he's sitting there. So both of those exams are specifically for our cervical, for our disc. Okay? Then any tingling or numbness in your upper extremity, we want to go through the full neuro. Okay, so whenever we have them here, we want to go C5, C6, C7, C8, T1, and then we're going to do this in lab the next couple of days. We've got C5, arms are here. C6, biceps. C7, tricep extension. C8, I'm going to have you break wrist like this. And don't let me break. T1, fingers are out like this. Boom, 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 like this. We typically don't do, but C5 is the biceps. Brachioradialis, so pull your thumb back like this. C6, and then T1 is the triceps. Okay? And then we always check radial pulse. Also with this, we can do our Adson, Allen, and military brace, speaking along the lines of this radial pulse. So with our radial pulse, we'll go ahead and I'll get on this. Pretend like it's coming off of this side. This is Ron him over here. So if we have any suspicions of having a TOS, okay, so a thoracic outlet, starting to look like that, we'll check the radial pulse. So we get this radial pulse. Wait until I find it. Just making sure he was awake. Okay, now you're looking straight forward. So my Adson, looking for scalenes, I'll have him look towards me and then take a deep breath and hold. And what I want to do when he does that is see if his pulse diminishes, right? That's for the scalenes. Now he's looking straight forward again. I abduct, externally rotate. I get on that radial pulse. Don't look away yet. You're looking straight forward. Get me a good pulse. Now look away. And I see if it diminishes. Okay? Then my military brace, I'm going to abduct, extend, thumb towards the ceiling. So he's an external rotation. Looking straight forward. I put my hand here, I brace him, military brace. Now he extends his neck. Extend all the way back. There you go. And that is for costoclavicular first rib. Okay? The Allen was for pec. Okay? Now, the Adson and the Allen can be for really kind of both. But we look at the Adson as being for the scalenes, the Allen being for pec, and military brace for costoclavicular first rib. Okay? All right? Now, I got those a little out of order.